thank you all. It's been a few years since I've been here to Beckman Laser Institute. I actually met Bruce as a graduate student, and we've grown closer, I think, over the years by the nature of being in this field. I met Tony Durkin at my very first semester at UT Austin. We did our PhDs more or less together. I think so there are several people here that I've known for many, many years. So it's a pleasure to come back here and talk a little bit. I really appreciate Rupsa Datta for inviting me as SPIE student chapter. She's the one who triggered this visit at the Gordon Conference, so I really appreciate that invitation, especially since I'm sort of combining this visit in two ways. This is one of the factors. The other is I have a high school senior who's coming to the area to look at schools. So I'm going to be visiting about 7 different universities over the next 5 days. 2 a day, which you can, given the distances here, is going to be really interesting that I'm going to be doing over the next 5 days. So it'll be nice to talk science because the next 5 days I get to be a parent, and that's it. Just be the chauffeur, if you will.
Are you giving talks at any of those other universities?
I'm supposed to give a talk at UCLA on Monday, but I don't know if that will happen because I'm letting my daughter decide what happens.
Are you making her come to the talk too?
She came to the one I gave at Northwestern. But this one, I came one day earlier, so she doesn't have to necessarily sit with me through all the meetings. So she's coming tonight and not here already. I did realize that as a laser person, I don't have a laser pointer, and there doesn't seem to be one here. So if I could borrow somebody's laser pointer, that would be great. Look, somebody left one up. I almost always travel with one, but there we go. All right. No, it's fine. This will work. That's all I need. So I can show. So, I do a lot of different kinds of things as part of my research. Most of it tends to be focused on clinical translation of optical technologies. And when I go to universities to present, and I apologize for the ECBO in there. This is not at all the talk I gave at ECBO. I'm not sure why it's looking like that, but the date is right, but the title is not. Apologize for that. But normally when I go, I sort of give an overview of different things that I do in my lab rather than a single topic. But I decided for today's sake to actually focus on one particular aspect, on one specific project, partly because it's a lot on my mind and there are different aspects of it that might be of interest to several of you. So that's sort of what I'm doing in my focus for the talk today. So for those of you who've never been to Nashville, by the way, I should tell you, I've even run into Bruce in the airport, in the Nashville airport, when I was coming back from a trip and he was leaving from visiting his family. So that doesn't mean Nashville is that small. It's just I think, a coincidence. But so we are currently housed in this building that used to house a free electron laser. For those of you who don't know what that is, it's the laser that was funded by the military Star Wars program. And it's essentially a basement large laser that's not really a laser. But it gave us 2 to 10 microns of wavelength tunability and was used extensively for many, many years. And in fact, the Keck Foundation paid to build the top 2 floors. There are 2 more floors underneath, which is where the laser sits. And it sits on 6 feet of concrete for radiation purposes. But the laser was shut down in 2009 and dismantled. But the biophotonics group was pretty much able to house ourselves into this facility. It's actually a very unique building. Vanderbilt has recently touted itself as being one Vanderbilt because we have a medical center, a part of the campus separate from the rest of campus. This building sort of represents one Vanderbilt in a large way because it's owned by physics, so that's the College of Arts and Sciences. It houses engineers, so we have our labs in there. But the 4th floor of this room is an orthopedics outpatient surgical suites. And so what you have in here is, so it's managed, therefore, because of the surgical suites, managed by medicine. So it's owned by physics, it's housed, occupied by engineering, and it's managed by medicine, which is a very rare beast to have in most places. So our labs are on the 2nd floor, 1 floor down from here with offices of all of us. This is an old picture, but I'll come back to it at the end of the talk as to why I'm showing this picture as opposed to a more recent picture of my group. But it gives you an idea that we have about 30 people roughly it's a number in flux because we'll have anything from 5 to 15 or 20 undergraduate students who work in our lab, depending on the semester at any given time. Research typically spans sort of everything from diagnostics to therapeutic use of light, as well as looking at novel imaging approaches. We haven't really, I mean, it's now beyond our biophotonics group. We're sort of merging with others, doing photonics research in the electrical computer engineering departments and chemical engineering and mechanical engineering. So now we even have sensing kinds of nanostructures for sensing applications as well within our group. I actually direct the Vanderbilt arm of the Center for Integration of Research and Teaching and Learning. So that's another thing I do besides doing biophotonics research. I also do teaching as research. And I'm not really going to talk about it, but I did want to put it up there as something that was looking at future faculty preparation for STEM college teaching. That's what that institute does. Our funding comes from a whole bunch of different sources, but I'd go ahead and put that up there up front. So this now focuses about my research. So all focused on biophotonics and optical technologies, and there's 3 main arms of what I do. One, I start from the other end. One part of what I do is using optical methods for screening and diagnosis, and I list just a few of the projects I have going, ongoing in my lab. A third of what I do is using optical guidance of therapy, or really surgery, and this lists some of the projects we have ongoing in that area, and one of those is what I'm going to talk about. And a third of what I do has nothing to do with spectroscopy and imaging for detection at all. This is where we, because of actually the free electron laser, invented the idea of using impulsed infrared light to activate neurons. And so that has developed into its own set of projects. And I'm not talking about that, but actually the last time I was here, that's indeed what I presented about here. So everything is a sort of fundamental idea, whether you took a diagnosis or guidance, is the idea that you can use light-based methods to improve diagnosis and treatment of tissue pathology. I should add that I now want to add tissue physiology and anatomy to it, because what you'll see in this talk is it's not about pathology at all. But what I would say is my own personal interest is I look at intrinsic methods of contrast. So I do not use any dyes, contrast agent, quantum dots, any of those things. They're all based on intrinsic methods of contrast. So when I look at this whole screen of the spectrum of screening all the way through surgery or therapy, the challenge that is presented to us as people in biophotonics is threefold. You can look at diagnosis, which is what most of the field does. And in fact, it's the most difficult problem, clinically speaking, because you need to be able to recognize a whole range of pathologies that could occur in that particular body type, whatever that is, whether it's skin or the breast or the heart or whatever you want to call it. But you need to be able to detect all the different things that could go wrong, typically for a true diagnostic tool. And physiologic variability is often a big confounder on making this technique, any technique you pick, most effective for the diagnosis as a problem. Guidance, on the other hand, and this is sort of why I got into it, not quite, is actually the simplest problem. You just need to know what you need to cut and what to leave alone. So really, you just need to know what you need to cut and where it stops, so that the question becomes almost more binary, if you will, and therefore more straightforward. But often, especially when you talk about guiding surgery, blood is your main confounder. So you've got to pick a technique where the blood doesn't necessarily interfere with what you want to do. Screening actually falls somewhere in the middle, because in screening, you just want to be able to identify something that's not normal. And then it goes to the next phase of the difficult part, to go to the diagnostic phase to figure out what is the problem. Right? So screening is somewhere in the middle. Typically, you want to know whether something is normal or not, or something is malignant or not, and then you send on that person forward to the next level of care. So that's sort of how I like to look at it from the clinical challenge perspective, because it helps me figure out where I want to be. And here I'm going to talk about guidance, which is sort of the lowest hanging fruit of our technology we should be able to use to move forward for clinical translation. Most applications of any kind of biomedical applications are typically driven by the technology. So somebody comes up with a cool new tool, whether that's photoacoustics or it's diffuse optical tomography, And then you go around, it's technically challenging, you develop the tool because it says something cool about it, and you have this tool, you then go about looking for a problem to solve with that technology. And so often you're stuck within the constraints of what that technology can do for you. And so more and more groups will add other things to it, whether contrast agents or other methods in order to make that work, that technology work. But often I feel what ends up happening, and I think Bruce has shown that focusing on the problem helps us get closer to the clinical translation. So you focused on breast cancer as a problem you want to solve and you want to move it forward. Similarly, you know, the problem is what is important. We want to affect patient care ultimately. So my work in this whole idea of doing teaching as research has essentially revolved around the idea of a book called How People Learn. And it presents for you what's referred to as a star legacy cycle. When you have a challenge, you generate ideas, you look at multiple perspectives, and then you research and revise that till you essentially test your mettle and go commercial with it, see how well it works, and you go with it. So if you looked at that as a learning cycle or a problem-based learning process, which is what we as engineers anyway do. I know I was a physicist before where you do things for the sake of doing things, then you become an engineer and you realize you do things to solve a problem. So I have to put in two hats at any given time, although my dean always says, no, as far as you're concerned, you're an engineer. Stop right there with your characterization of yourself. But as a biomedical engineer, what I do is solve problems in medicine and biology. So let's apply this idea of problem-based learning to biomedical photonics research. Okay? So I'm going to tackle it accordingly. So the problem I'm going to talk about is the parathyroid gland, detecting the parathyroid gland. This problem or this project arose from actually a surgical intern who had heard me present some work I had on brain tumor demarcation that Bruce referred to and came to talk to me the next day. She walked in and she said, you know, I'm right now doing endocrine surgery rotation. And I noticed that the surgeons, we as surgeons, have a very difficult time finding the parathyroid gland. And I was wondering if any of your optical techniques could be used to solve this problem. I didn't know who she was. She just walked in. I had a gazillion other projects going on. Not really sure I want to start one more project. So I told her, why don't you go look in the literature and see what's being done, right? Because it seemed like a simple enough problem. And she came back the next day and said, I found 2 or 3 papers on looking at thyroid cancer and maybe even 1 paper on parathyroid cancer, but nothing much just for looking for the gland that I could find, at least optically. And she had already done the research on what's being done about other techniques, and I'll talk about that in just a second. So the first thing I had to do was, what's the parathyroid gland? Okay? Hey, I haven't done medicine, so I do not know. Every time I tackle a problem, I go learn about that particular problem. So I looked it up. The parathyroid gland are 4 glands the size of a grain of rice. Okay? Sits right here. What does it do? Anybody know? Regulates calcium in the body. That's its sole purpose. It regulates the calcium. It senses the calcium in your body and lets the other parts of your body know you need to produce more or less. That's what it does. So the flip side of that is that, so it's a problem that is important to know where it is because it's so tiny. Thyroid cancers especially, or surgeries for thyroid, which is what thyroidectomy is referred to, there's a lot of them that occur per year in this country, and the move is more and more for not specialists to do these surgeries, but just the general surgeon to do this. And because when the thyroid, you're removing these thyroids for being abnormal, they're typically enlarged, the parathyroid gets lost in there. And they want to protect the parathyroid gland and leave it alone if it's there. Otherwise, these patients will in fact have lifelong problems with calcium regulation. Okay? In fact, if you just go online and do a Google search on this, you will find a whole bunch of blogs where there are patients who've undergone this surgery are now asking the question of whether they can sue their surgeon because they now have all these calcium problems. And if they were to look at the fine print of this consent form that they sign, actually it's not in fine print, it's very explicitly stated, this is a problem you're going to face because they can't guarantee that the parathyroid gland cannot accidentally come out. In fact, if they find it post-surgically and it's well perfused, they will actually go and just suture it on the side of the gland and it actually still does its job. So finding the parathyroid gland is important. And so that's the challenge that the problem statement as an engineer that was faced to me is to identify the parathyroid gland relative to everything that occurs when you do this surgical procedure, actually right here, because they just do a line and open it up and do the surgery right here in real time in a bloody field in the operating room. The way it's done right now is people have used ultrasound, CT, MRI, and all of these procedures are typically done preoperatively, not intraoperatively. And the problem is typically high false positives of things that they think are parathyroid when they're not. And most of these have been done for cases where the parathyroid is actually diseased. They want to find where the cancer is or where the abnormal gland is. So it actually, all of these methods rely on the fact that the parathyroid is in fact diseased. And they cannot use these techniques if the parathyroid were actually normal. So in a case where, which is what the majority are, where the thyroid gland is diseased and you're doing a thyroid surgery, finding the parathyroid gland, none of these techniques would work. So that's what we need. In addition to that fact that real-time intraoperative system to guide, to identify or detect the parathyroid gland that's highly accurate and provide real-time feedback regardless of disease. I need to be able to find a method that can detect this parathyroid gland, whether it's normal or not. Okay? So that's my challenge. And what we found, so we took this, and some of you might have heard me say this before, but we tried all the different things. We measured reflectance, we measured OCT, we measured fluorescence in the UV visible, and then we measured Raman. Okay, Raman was the last thing we did because a lot of what I do is about using Raman spectroscopy, but I don't always want to use it because it's a difficult technique to implement in vivo. So there was nothing special about its reflectance. There was nothing, at least in the ranges we looked at, there was nothing special about its UV visible fluorescence, nothing that made the parathyroid stand out relative to the thyroid. And there was nothing special really that we could, OCT as such, because it was kind of small relative to everything else, and I was having a hard time envisioning at that time how to do this with OCT. So we said, okay, let's try Raman. And we measured Raman of a piece of dog, canine, parathyroid, and thyroid tissue, and our detector saturated when we measured the parathyroid. You automatically assume it's stray light, something coming from somewhere in the background. So you make sure all the lights are off and you put little black tape on every LED. You'd be amazed at how many LEDs are there in a dark room. You put a little tape, still saturated. I had never worked with dog tissue before. I figured there's something wrong with a dog, so let's just go work with human. So I got human thyroid and parathyroid tissue, still saturated. I had to turn down my integration time to from 3 seconds to 300, actually, to 3 milliseconds in order to get anything, to be able to actually see my Raman, which is very noisy at that point in time for obvious reasons. And I was still like there must be something wrong in the lab, some stray light coming in, I don't know. And I have very good collaborations with the medical school, so I went ahead and wrote an IRB to go and do in vivo, take my system, which we've done with a lot of different other parts of the body, and said, let's just go measure and paper and see what's going on. And so pretty much that's exactly what we saw. We had to turn from the thyroid gland, we could get the Raman measurement, no problem, but in the parathyroid gland, the instant we measured it, we had to turn down the integration time by 2 orders of magnitude to get any kind of Raman signal. So the student went ahead and measured, actually it was a postdoc of my clinical collaborator who went ahead and measured like 5 or 7 patients, and in fact published that at a conference proceedings. And I sat there one day and I was like, why are we saturating? Why are we doing this? What is going on, right? So I decided, let's just try something. Let's keep the Raman light source. Let's just use an ocean optics detector and just get a probe and run it by and just measure 3 milliseconds and measure fluorescence. Let's just see what's going on with the fluorescence. And that's essentially.
What was the light source you were using?
785, which is what we typically do for Raman. So 785 diode laser source. Kept that, added an ocean optics spectrometer, and ran it through to see what we get. And that's what we got. Just the fluorescence of the parathyroid was 1 to 2 orders of magnitude sometimes, anywhere between 2 and 20 times greater than the thyroid, okay, so which is that. Everything else was pretty much flat. And we measured everything else we could find, fats, nerve, lymph, whatever else we could find. Everything else was pretty flat, and this was, so clearly, so that's our system, okay? There's our diode laser that we use at 785. There's the ocean optic spectrometer. There's a fiber optic probe right there, and a computer. That was it. That was our basic system. And there's a little long pass filter right there inside the SMA port to block the laser line. So we have done now, I think the next slide you'll see 121 patients. This is data from the first 35 where we had histological validation. So remember, if the patient is undergoing thyroid surgery, only the thyroid comes out. So we can't get histology from the parathyroid because it's normal. You want to leave it in there. If it's a parathyroid surgery, then the parathyroid comes out, but the thyroid lives there, so we don't have histology. So we can't get histology for everything we measure. That's just not possible, at least in the clinical situation, except in 35 patients that I'm showing you who actually had concurrent thyroid and parathyroid disease. So both the things came out, so we actually had histology from both types of tissue. We've since done canines and other things to validate this idea. We got this, it works 100% of the cases that we've done so far. Okay. You will rarely hear that on any project that you've ever done, that it works 100% of the time. Sometimes it can actually be as small as 1.2%, or 20% more, which is still 20% signal to noise difference. It's pretty darn good between two categories you're trying to find. Usually in Raman, I'm looking at less than 1%. Okay? So 20% is huge. 10 to 20 times greater, wow. Right? So here is some new data that I have not really shown anywhere else, where one of the things I noticed was there's a huge variability. I'm telling you 1.2 to 11 times difference in signal. So why is there so much difference, right? So we did this. This is looking at patients and looking at the parathyroid signal from a variety of patients, normalized, and I apologize that that got stuck. This is normalized to the thyroid. Remember, thyroid has a little bit of signal, so I was normalizing to that thyroid, normalizing to muscle, which is nothing. There's no signal there, or fat, which also has not much signal there. And this is the raw signal. Okay? I'd like you to look at this one, really, because that really tells you more, is that there's no statistical significant difference between whether the patient had benign thyroid disease, malignant thyroid disease, or hyperthyroidism. And typical case for doing parathyroid surgery is actually hyperparathyroidism. And there, consistently, there was a little bit less fluorescence, if you will, compared near-infrared fluorescence compared to everything else. And there's the pizza guy who just walked by. I don't know if you'll want to try to grab him. He just walked by and went that way. So just thought I'd let you. I just saw red boxes fly. He just walked that way. So. Okay, I think he delivered. Oh, there they are. So if somebody wants to grab pizzas, please feel free to do so while it's hot. I have no problems. I'll tell you, I gave a talk in Scotland not so long ago. And, it tends to be gray there. And one day, while in the middle of the talk, somebody noticed a rainbow outside the window. Okay? So I had to pause my talk. We all walked to the balcony that was behind the screen and admired the rainbow and the pretty scene. This is in St. Andrews over the golf course. There was the ocean in the background. Beautiful rainbow. So we all stopped, took pictures of the beautiful rainbow, came back in, and then I continued my talk. So interruptions in talk, fact of life, happens. Whether it's a rainbow or pizza, it doesn't matter. So, one of the things we've noticed, and I don't know what it means yet, but that the hyperparathyroidism fluorescent signal from the parathyroid gland is a little bit lower than everything else. All the other categories. These are the 4 primary categories for which the surgeries help. Looking at the thyroid data, on the other hand, and looking at it, we don't typically normalize that. We found malignant thyroid disease typically has a little bit greater fluorescence compared to everything else, and they're not statistically significant. Again, this is really to tease out the issue of how this variability in fluorescence between thyroid and parathyroid that we see. Okay, and then if you look within a particular patient, and so look at the normal, and it happens to be a few cases, we have only a handful of cases where patients who had a diseased parathyroid in one side, but the other side was normal, and you looked at comparing the fluorescence of the diseased versus the normal parathyroid, not much different between the two. Just looking at variability intra-patient as opposed to inter-patient, if you will. Again, this is all just analyzing or trying to understand the variability in the signal. So it's variable, but it occurs in every single one of those 121 patients that we've measured so far. And actually, we're now at 149, I think, and it's still 100%. Okay? So within a patient, for example, let's look at the variability. This is a question. This technology is now being licensed, so these are the kind of questions the company comes in, asks us. How variable is the signal across a gland? And so for a given patient, this is all the thyroid signal, and this is all the different parathyroid signal. So essentially, the parathyroid signal is quite variable compared to the thyroid signal, which is pretty consistent, okay, just within a patient. But even the lowest parathyroid signal is still quite a bit greater than everything else that fluoresces in a particular patient. Here's a patient who has thyroid disease. The previous was a patient with parathyroid disease. And there is a little bit more variability in the thyroid signal when the patient has thyroid disease, but still the difference is very, very significant and greater. Okay? So in these cases, you're looking at 3 to 4 times between the parathyroid and the thyroid. So just to give you a histological sort of validation on a handful of cases, right? This is sort of your gold standard of doing independent validation. So when you looked at 8 patients who actually had pathology, so that you can really look at this, we found, so for every case, we asked the surgeon, how confident is he when he's making a parathyroid measurement that that is indeed the parathyroid? And it gives you low confidence, high confidence, medium confidence. So that's what this column is referring to. Okay? So this is the surgeon's assessment of what that particular tissue is when we were measuring, and they were meant to be all parathyroid except one way he said, I don't know what this is, but let's just measure it anyway. This was his confidence of what he thought it was, and that was our ratio. Okay? So in one case, when he thought it was the parathyroid with low to medium confidence, our ratio was definitely below 1. So it was definitely not, we didn't think it was the parathyroid at all, and histology indeed. He removed it, and the histology, because it was diseased, and it did indeed come back as not being parathyroid at all. And here's another case where he didn't know what it was, and he had pretty low confidence that it was the parathyroid, but our ratio definitely showed that was the parathyroid, and indeed it was. That's just showing you 2 examples where when something says it's 100% accurate, here's histological validation that it is indeed accurate. Because right now surgeons just use their eyes to do this, okay? Just to give you a flavor of that. So this is the first technique I've ever worked with that has been 100% successful. So it's a novel space, if you will, to be in. Clearly something I think that's going to be the pivotal moment of my research. This is what will get out there and probably help patients, right, out of everything else that I've done so far. Because you can't beat 100%, especially when you're not touching it, you're not really doing it, you can't beat that. So your question is, okay, what's going on? What is this signal? Why has nobody else done this before? Because if it's that easy, why hasn't it been done before? I have no idea. Okay? People usually, typically those who work with fluorescence will tell you biological fluorophores pretty much occur in the UV visible. The longest known biological fluorophore is the porphyrin, whose peak is roughly in the 600, 660, 630, in that range. Okay, it's between 630 and 630. That's the longest known biological fluorophore, which is why everybody likes to build these NIR contrast agents so that there's no autofluorescence is minimal, and so you can look at things and introduce dyes and things like that in that area. Now, if you talk to most of the people doing Raman, they'll tell you that you do indeed measure fluorescence out in the 785 range. There's a lot of tissues where you have fluorescence, and we're usually typically in the Raman trying to subtract out the fluorescence. And their skin, for example, actually typically has a lot of fluorescence, and to get to the Raman, you've got to do some intricate fluorescence fraction method to look at skin Raman. So there are lots of biological tissues that have signal, but still, when you look at every textbook, there isn't anything known in that range. So our challenge was to figure out, okay, what is this fluorescence? So I work in 2 ways. On the one hand, to go ahead and develop this 100% accurate technology for clinical care while trying to figure out what is it that is actually causing the fluorescence. So when you present this in the American Association for Endocrine Surgeons, they go, what is causing it? And I said, we don't know. It's like, oh, that's okay. As long as it works, I'm ready to use it tomorrow. And there is a long list of surgeons who are ready from all over the place, okay, who are more than willing to start using this to help them. Then there are some surgeons, as all surgeons are, who go, well, I don't really see how it can help me, right? You always have that. But there's still many more surgeons, especially general surgeons, who will be very happy with such a tool. So my question was, okay, what is this thing that is essentially having a peak at about 822 to 826 nanometers? Whatever this fluorophore is has to have a lot of it in the parathyroid, a small amount of it in the thyroid, and not at all in all the other things in the neck. Okay? So our first hypothesis, we haven't validated or invalidated it yet, was calcium sensing receptors, which is what the parathyroid is known for. We've looked at the parathyroid stimulating hormone, and it has no signal. So that was not it, by the way. So calcium sensing receptors are known to primarily be present in the parathyroid gland in large quantities. There's about 5% in C cells of the thyroid. It is also known to be present in the kidney and the colon. And I think here I only have the colon. We measured some colon. We also measured some kidney. And you get signal along the lines of the thyroid from those two. Saying maybe it's the calcium sensing receptor. Of course, since then, in the last 2-3 months, since we got a recent funding, because these are expensive, when you start doing molecular microbiology experiments, it uses up funding very, very quickly. Okay? Every antibody and everything you want costs a lot of money, and you've got to use these columns and things, things add up very quickly. So we got some funding to go ahead and try to do this. So I'm not a biologist, never done any of these experiments. I can only interpret more or less what my student did. So in this case, she did differential centrifugation, where you centrifuge things to get different size particles at different levels, and you separate them out. And so when she did that, and looked at the fluorescence of the supernate that's left from each level, that's a blank, so clearly showing blank, has no fluorescence. When she pulled out things, the final stuff that was left, it has a little bit of red, but not much. The pellet, which was sort of what you might consider having mitochondria, secretory granules, and lysosomes and stuff like that, had quite a bit. This is the actual debris, and if you really look, the debris has fluorescence too. We broke things up, but it's still fluorescent. We've minced the tissue, and it's still fluorescence. You let it sit at the table for hours or even a couple of days, and the fluorescence is still there. So it doesn't fall off. It's just very robust and just there. Okay, I have no other way to put it. So we did some immunoprecipitation with calcium sensing receptors. It was somewhat inconclusive because we should have only seen the signal right here, but we also see it. So this is the beads with the antibodies for the calcium sensing receptors. But what is left after we do that also has fluorescence. Okay, so this is the total thing, and this is splitting that up into these two bits, and they both have fluorescence. So it may be the calcium sensing receptor, but there's something else too. Maybe what it sits in or something like that. So I don't have an answer. I'm just eliminating, and going through the experiments that we've done. So here's sort of the results from a density gradient centrifugation that shows how much of what there is and how much fluorescence there is for all the different fractional sizes that came out of this centrifugation process. And you see something has a strong signal in the fraction numbers 3 and 4, and out here in 12, 15. This is a paper published that shows all the different fraction numbers and what the cells are, and you can tell by the colors. For example, the green line that goes up here is essentially something that refers to aryl sulfatase. I have no idea. Please bear with me, okay? These are all meant to be essentially secretory granules and mitochondria and lysosomes in here. And our peaks fall somewhere where the secretory granules are, which is right about this, between these two, is where one of our peaks fall. But there's nothing out in our lighter fraction, if you will, the lighter things that are in there. These are based on density, so there's something that's light and something that's more dense. We took those two fractions and looked at it under the electron microscope. And this is the dense fraction, and this is what it looks like under the electron microscope. Not that that helps me to know, but we think it's something circular. There's cellular-like things with round, dark particles in there. The sizes of these things are right here, which is in the right size range of secretory granules. So one hypothesis, that's maybe what it is. But the lighter fraction, remember also, which had signal, that's what that looks like. My student came, I saw little webby things in the electron microscope, which could be like a cell or some structure that was broken apart and you're seeing the walls or something like that. I'm looking for somebody who knows, who can read the sort of cellular morphology in their electron microscope to help me figure out what I'm looking at in this particular case. But it looks like something when intact has fluorescence, and when you break it apart, both parts of it also have fluorescence. Okay, almost through here. So these are the sizes of those things. So the idea right now is that we're seeing it in some kind of membrane, and we're also seeing it in the granules potentially as well. That's our current, is where we are at in trying to figure out the mechanism. Don't have the answer. In fact, I told my graduate student, I mentioned this to somebody earlier, that it's in her, part of her, one of the specific aims in her PhD is to figure out the basis of this fluorescence. And I told her it may well be that all you'll graduate with is knowing what it's not. Okay? And I told her that was okay, because this may be a lifelong work to figure out what actually is going on. So great, you know, the system I showed you before, which is this thing, is a probe-based single point at a time. But ideally, to help in the surgery, you want to do some kind of imaging approach. You want to image this and find these glands, even though they're tiny, so that it's more practical to use from a surgical perspective. Okay? So we tested out 3 different systems. And actually, this is the part that I presented at ECBO last year. And I'll show you the most recent work as well. So we tested a cool CCD camera, sort of the gold standard in a CCD camera that we used for spectral imaging, which should work, clearly. We used this is an inexpensive $1,000 near-infrared viewer, actually found it through the exhibition hall at Photonics West. So we bought one of those, stuck a lens in front of it, and decided to use that. And then in the operating room, the stores has an endoscopic camera that was being tested for urology applications, and we decided, and it's really being used for blue fluorescence, but we figured we can actually get rid of the filter in there and shine near infrared light and see if that will work. So we compared these 3, and some of the cool CCD cameras, in fact, not linear as a function of power as well as as a function of distance when it comes to the field of view. Our ideal clinical field of view is about 10 centimeters. Okay, we want to be able to look at about a region that big. The cool center is not linear, but you can see the characteristics. Here's the spatial resolution that you can get with each of these systems. And this is plenty for what we want. We want about 500 microns to a millimeter resolution, and all of these work just fine for what we want to do. And when we look at it near infrared light, by the way, endocyanine green, ICG, has a fluorescence in this range. You can excite at 785, and actually you will burn the ICG crystals if you use 785 because it's so highly absorbed. So this is a low concentration of ICG, which deteriorates very quickly, so we have to make a new batch every time we do it. But this is what you can kind of see these are 2 concentrations, 8 micrograms per milliliter and 2 micrograms per milliliter, looking at these dyes using these 3 and what kind of ratio. So this simulates thyroid fluorescence, that simulates parathyroid fluorescence. You can kind of see what each of them do as a ratio. So this is sort of the engineering, figuring out what's the best instrument. Here, in this light, it's kind of hard to see. There are actually 2 pieces of tissue in here. But I mean, I think you can see enough. It's okay. Bruce, it's okay. You can sort of see the fluorescent red hue, if you will, from the blob. That's your parathyroid. See through it. So you can kind of see, that with each of these, you can see this fluorescence even at 0.02 milliwatts of power. Okay? It's hard to see. You can now see it. With the lights off, you can kind of see it. This signal, you will need more power more around here, if you will, somewhere right here, if you want to have the lights on and be able to see this fluorescence. But you can see it with as little as 0.02 milliwatts, and it looks nice and bright, of course, at 80 milliwatts of power. Here's the thyroid versus the parathyroid gland with the 3 cameras, and for obvious reason, that's the parathyroid, that's the thyroid, if you didn't know that already from its brightness. This is the cool CCD camera, looks beautiful, right? But it's big, it's bulky, it's fancy, do you really need that? And so this is the other 2 cameras that you can kind of see. You see the ratios, this is sort of one of our low end, it's only 2, but you can kind of get the same idea. You get the same parathyroid to thyroid ratio regardless of which camera that you use. This was done at 2 milliwatts of power, okay, and looking at a 1-inch area. So bottom line is you can try any of them and it works. So this is the new data that I have. We actually used one of the we've actually used more than one, 2 of the cameras. We didn't take the SpectraMax, Photon Max camera. And here's that's the parathyroid gland, okay, compared to the thyroid gland. And as you can tell, it's not really that different looking, but that's where the fluorescence came from. And when you overlay those 2, that shows up as being the parathyroid gland. This is done in vivo. This is intraoperatively done, and we've done this in a few patients to show this is what it looks like. Okay. So this clinical testing is in process. So we're trying to figure out the best kind of instrument for the imaging way to use. This is the sort of what we want to aim for to be able to do this, but with the lights on, so you don't have to do what we do acrobatics that we just have to follow to do. This is licensed by the company named Anisys Instruments. It's out of Santa Barbara. They are actually an IR nanomaterials microscopy company that saw our paper and patent and jumped on the board, and within 4 months signed a license agreement for this technology. The day we signed the license agreement, stores came knocking on my door wanting to do the same. But it had already been signed, so I just referred them to Anisys at that point in time. And an interesting story in this point is they talked to Anisys and then essentially told Anisys, well, I don't think your patent is going to hold anyway, so we're going to go ahead and try this and do this clinical testing with our cameras in Germany. So the very next month, I went to Germany to EGBO and presented this, because you all know in Germany, in Europe, first disclosure is it's no longer patentable. So I went ahead and presented that there. That's all I could think to do. I'm not going to fight a big beast like stores. So they might still come up with something. I haven't heard anything since. But our goal is still, so what Anisys has decided is its first generation instrument is going to be just a point-based measurement device, because the surgeons feel like they have more control pointing exactly where they think is suspicious and making measurements from it. And that's what they're building as the first prototype. They've promised the first prototype to me actually by November 1st, so we can go ahead and test it on patients before we give the true prototype to 4 other institutions, not Vanderbilt, so we can do sort of clinical trials for FDA purposes. I think I could talk more. These are some of the other sort of projects where we're always looking at the problem first and trying to figure out what the solution is. So looking at nerve monitoring, I mentioned too. So something else we've been doing more recently is looking at soft tissue sarcomas and guiding that surgery, using spatial offset Raman spectroscopy for breast margin assessment. This is just some other projects we have ongoing. So the basic idea I want you to leave with is, of course, that following this problem-based approach to research actually serves to develop very targeted solutions for specific problems, medical, clinical problems, and has therefore, to me, a more tangible solution, presenting the biophotonics as a commercially available, viable clinical tool, getting us out there sooner rather than waiting 20, 30 years for it to happen. And there are many ways to impact, and we have a whole spectrum of it, and I really think doing this for surgery is our first lowest hanging fruit to make it happen on a routine basis. There are many more problems out there that we could do something similar with. So now, this is the clinical staff, obviously the surgical staff of the medical center. We couldn't do none of this work with them. The clinicians this Lisa White is the surgical intern who came and sort of triggered this whole area. John Fay was this endocrine surgeon who was part of it. He came, he left Vanderbilt, so he started working with James Broom. He left, and now we have Carmen Solorzano. So clinicians come and go. That's sort of the moral of the story, by the way. Every one of them has worked very enthusiastically with us. Melanie Goer, that's the Melanie. She's actually Melanie McQuaid now. She got married this past year. Is the current graduate student working on this project. But the student who worked on all the early stuff is Dean Paris, who's back here, who actually passed away from neuroendocrine cancer in 2011. So I wanted to dedicate this talk to him. He sort of did all the work to sort of develop this idea before he passed away. He was diagnosed in June and passed away by December of 2011. So with that, I think I'm done. Thank you for your attention.